This is one of the we can say this is a huge topic. Why? Because we had got more than 600 muscle tendons in our body. If you want to talk about each and everything, so it will be very difficult for you to understand. So I think you all are uh, learners. Maybe you are all students, right? So what I will be trying to focus, I will try to give you just an overview about the tendinopathy, and we'll take only few tendinopathies and we'll discuss about those things. If you have any doubts, yes, you can ask me at the end, or if you are able to ask me in between also, then I can also explain, right? So let me start. So these are the content as given by our IAPM. So they are asked me to cover the tendinopathy, the definition, prevalence, what is the clinical significance, what is the role of ultrasound, pros and cons, scanning protocols, grading, and they had asked us to cover few guided interventions, right? Let me start with one. What is called tendinopathy? Tendinopathy is defined as a failed healing response of the tendon with haphazard proliferation of tenocytes, intracellular abnormalities in tenocytes, disruptions of collagen fibers, and subsequent increase in non-collagenous matrix. Okay, so this is as such as a definition, no need to mug up. So something it says that there is something, an issue in the healing process and something abnormal which is happening in the tendon. How it clinically gets relevant. So here they say it's impaired tendon healing characterized by pain, swelling, and impaired performance. So when we are learning pain medicine, maybe in 20 years back, that time, so we had a different term called tendinitis, tendinosis, tenosynovitis. So as a tendinitis says, it's an inflammation in the tendon. So in tendinosis, it says that it's a degeneration. In tenosynovitis, there is says that it is the inflammation of your synovium. Nowadays, all these terms are absolute. So even when we are learning ultrasound, we are thinking how to differentiate between a tendinopathy and tendinitis, or how to differentiate between a tendinitis and tendinosis. Now the term is totally absolute. So the only term which we use it for tendon pathology is tendinopathy. It's a spectrum of, we can say it's a spectrum of diseases it will be covering. So from tendinitis to tenosynovitis. So before we go to know about the pathology, we should know how the tendon will be. Yes, the basic unit of your tendon is your collagen fiber. So few fibers, they form the collagen fiber, which again forms the primary collagen. This is called a subfascicle. Then bunch of your primary collagen fiber bundles form the secondary. Then bunch of your secondary fiber forms the tertiary. These three fibers are lined by endothelium. And a bunch of your tertiary fibers form the total tendon, which is covered by epithelium. To the surprise, a tendon don't have any nerve supply or a vasculature. It don't have any vessels. If you are seeing any vessels or a nerve inside a tendon, means the tendon is pathological. Physiologically, tendon won't have any vessels or don't have any nerves, right? So what is the function of a tendon? As most of you know, the most contractile structure in our body is muscle. How the muscle acts. So it is conducting its contraction to our tendons. Usually when you look at most of our bodies, tendons is the one which crosses the joints. Most of the time muscles rarely crosses the joints. So it is a tendon which crosses the joints. So that is the one which is responsible for the movements of your joints, or it is responsible for your transfer of your load, right? So again, it is the most important storage part of your energy. So whenever you want to contract, whenever you want to relax, we need some energy. That energy is provided by your tendons, right? So how it acts? Most of the time, when you look at the normal anatomy, if you look, the tendons are not, these fibrils are not straight. They are in a cream waveform, just like a rubber band. When you are keeping a rubber band relaxed, it will not be taut. Okay, so once it is relaxed, this is the one which is giving the viscoelastic property of the tendon. So whenever you are expanding your rubber band, it will stretch up to your limit, right? So we can here say until this crimp waveform becomes more straightened. After this, you will feel resistance. When you give more resistance, you will feel again the strain in the tendon. Once you are giving more pressure, then it will tear off. The same thing is happening in the tendons, right? So we'll go for the prevalence. It's just in rough idea because we can't give prevalence of tendinopathy as a whole. Because tendinopathy, I told, it's a spectrum of diseases, right? So just for your interest, rotator cuff tendinopathy is the most common for shoulder pain. It's around 80%. It's very common in general population. It's around 2.5 to 7.5%. And in women, so we can put it in the reverse. The calcic tendinopathy will be more common in women, right? So lateral epicondylis is the second most common tendinopathy, which will be there in 1 to 3% of the adults, and those otherwise called as tennis elbow, right? It's more common in tennis players. It's more common whenever it becomes aged. So we can say whenever we are becoming more aged, the rotator cuff tendinopathy, lateral epicondylis are the one which we frequently see of. Middle epicondylis, again otherwise called as golfer's elbow. Yes, it's common in golf, baseball, and javelin throwing athletes. It's not more common than lateral epicondylitis, but it is around 1% of general population. From coming to the hand and wrist, decurrence tenosynovitis, yes, it's more common in the athletes. I think those who are involved in cooking activities, those who are cook, so are they are doing BD activities, they are BD rollers, so they will be using the thumb. They have more predominance of decurrence tenosynovitis. It's more common among the women, not doesn't mean it is only uncommon in women. So it is more common in women, around 2.5% per 1,000 women. Gluteal tendinopathy, yes, it's the most common cause for lateral hip pain. So it occurs in sedentary lifestyle patients. So it doesn't mean those patients who are in manual or those are athletics, but it is very commonly occurs in patients above 50 years. Patellar tendinopathy, yes, jumper's knee, right? So it's very common in jumping athletes and recreational jumping athletes. So one more thing, these patients we routinely we don't see the for like athletic patients in pain clinic. Yes, few of the patients we may be seeing, but we'll be seeing those patients who will be have more prone for this patellar tendon, especially these obese patients and tall patients. So these are the patients we may be seeing in our clinic. Achilles tendinopathy, yes, it's very common in the runners, but the practice which we are having, we will be seeing more patients with Achilles tendinopathy who are more prone because of the obesity and diabetes, right? So this is just in giving a rough idea about the prevalence. Coming to the pathophysiology, as I have told, whenever you are stretching the rubber band, it's get teared, right? So whenever you are stretching your muscles or stretching your tendons, obviously it will be teared off. So those who are doing sports and athletic activities, those who are unconditioned, for example, if I'm going for a walkathon for 10 kilometers on tomorrow, yes, I can expect I will have a tendinopathy. And those patients like flat foot or using high heels, they will have those this Achilles tendinitis because of this flat foot and all those things. And again, increase in age, obviously above 60 years you can expect, but most of the time these patients usually present after 70 years. These are the things which they are getting more prone for. There are certain diseases which make the tendons more vulnerable, not because of they are vulnerable to damage, it is because of the lack of healing. That is because of diabetes and for drugs like steroids, fluoroquinolones, and sometimes it is not mentioned in any books. Smoking again is one of the culprit for tendinopathy. So it has been not yet proved, but still smoking plays a role. So this is the spectrum of things which happens in tendinopathy. So whenever you are doing a normal activity, yes, whenever you are doing a load, whenever you're walking for 5 kilometers, it's okay. You are doing routinely for 5 kilometers, okay, your tendon will be normal. So whenever you are giving an excessive stretch, it will go for 3 phases. One is called reactive tendinopathy. Second one is tendon disrepair. Finally, it is called degenerative tendinopathy. What happens in reactive tendinopathy? It happens whenever you are giving a small, for example, I climbed 10 floors on a day immediately. Yes, I will have reactive tendinopathy. What will happen? So there will be some sort of non-inflammatory thickening happening in the tendon, or edema it will happen. So that will cause the tendon to swell up, but the collagen fibers are still intact. And there won't be any neovasculogenesis, right? So this is the phase where usually after few rests for maybe around 3 weeks, they usually get back to normal. So whenever giving more stress over a prolonged time, then it will go for tendon disrepair. Here, not only the extracellular matrix increases, it is the collagen fibers which also get damaged, right? But still, even in this phase, it is possible to get back to normal life. So even the tendon can get it repaired and come back. There is a final stage which is called degenerative tendinopathy. This is the phase where you will have a lot of tenocyte death. So the lot of fibrils will die off, tenocytes will die off, and only you will have only extracellular matrix expressed in the form of proteoglycans. And here you will have vasculogenesis. And this is the phase, it is very difficult to get it irreversible. We can say reactive tendinopathy and tendon repair are the phases where you can get back. Degenerative tendinopathy is the phase where you can't go for reversible phase, right? So what are the features in a tendinopathy as I had told? So there is a loss of collagen fibers, especially type 1. Then there is obviously increase in tendon thickness, either it can be local or it can be global. There can be increase in extracellular matrix, especially in the form of proteoglycans, and finally neovascularization. These are the cardinal features of tendinopathy. So if you say if your patients have tendinopathy, then you have to mention at least all these points, at least 3 points, right? So loss of collagen fibers, increase in tendon thickness, increase in proteoglycan, and finally in later stages it can be neovascularization, right? So what are the structural changes which can happen in tendinopathy? As I told, we had got degenerative tendinopathy, which we had already covered. So usually the patient will have either mild tendinopathy. So with time, they may go for moderate tendinopathy, then they can go for severe tendinopathy. From severe tendinopathy doesn't mean it's like a ladder. Sometimes those patients who are having mild tendinopathy, whenever they go for some exaggerated activity, they can go for partial tear. So we can say this is a clinical spectrum from top to bottom. So mild tendinopathy, moderate tendinopathy, severe tendinopathy, partial tear, that is partial full thickness tear, then finally it is called complete tear. So these are the clinical spectrum of tendinopathies which we can see in our clinical practice, right? So what are the clinical features as such for tendinopathy? Yes, most of these patients will be coming to you with symptom of pain. So initially they will say have the pain whenever they're doing an activity. Sometimes what happens with chronicity or with repeated activities, they will have resting pain also. So we use a term called irritable tendinopathy. So this is the one which we routinely see in pain clinic, because most of these patients can be seeing, for example, the patient says whenever they have pain in oil activity, they may be seeing an orthopedician or a general practitioner. They may be managing conservatively, they will get rid of. But irritable tendinopathy is the one which most commonly bring those patients to a pain clinic, right? So what they do, they will have pain during night time. So nocturnal pain is the most important feature of this irritable tendinopathy. So you may be seeing a lot of shoulder patients who will be coming and says, so I'm finding difficulty in night and I am not able to sleep because of this pain. So where we will be actively intervening and the success rates are relatively good, right? Second thing is the patient may come with swelling either because of the tendon or because of the underlying synovitis or bursitis, or when it is a tear, it can be a retracted tendon, right? Then third most common symptom which patient may say is they find difficulty in the range of movements. So whenever you are saying, whenever the patient has got subscapularis, they will have difficulty in internal rotation. Whenever they have supraspinatus, they will say they will have difficulty on abduction. So whenever they, for example, I'm just giving an example. So they will have restricted movement depending on the tendon which was involved. And finally, in advanced stages, they may complain of some crepitus sound, right? It's very rare, but these pain, swelling, and restricted range of movements are the cardinal features of clinical features of tendinopathy, right? So what is the grading based on the clinical finding? Stage 1 says the patient will have pain only after intense sports activities, does not impact the performance. That is stage 1. Stage 2, they say they will have pain before and after the activity and even during activity, but it does not impact his performance. So obviously stage 1 and stage 2, mostly they will lead their practice. Stage 3, they will have pain activity with slight restriction in performance. So these may be the patients which may be seeing us in the pain clinics, or it may be in general practice. Stage 4 and stage 5 means it's a severe restriction, and 5 means they can't even do any sort of activity. They have to quit the sports activity. This is for those for young peoples, right? So this is not applicable for degenerative arthropathy which we see after 40 years. Coming to the main topic, ultrasound in tendinopathy. Just I had covered, I just given you an overall view about tendons, how the structures will be. So what are the features of tendinopathy? Then how the ultrasounds is going to help us. Now we'll be just covering up. So what is the advantage of ultrasound in tendinopathy? As most of you know, that is a cost-effective way and it's a cheaper modality to see the soft tissues, right? So in addition to MRI, for example, in comparison to MRI, ultrasound has got the best view of fibrillar pattern, which is the most important feature in tendinopathy. And again, the neovasculation part can be nicely seen with ultrasound. So even if MRI, they say this is the gold standard for confirming your tendinopathy, but they will give you an idea about the thickness and all. But the fibrillar pattern and neovasculations are the one which we can really see only with ultrasound. So this is the advantage of ultrasound over MRI. And again, as most of you know, it's a dynamic study, right? We can see the impingements. So these are the few advantages of ultrasound, but doesn't mean we have always an advantage. There are some few disadvantages. What's obviously we all are in learning phase. Though even myself are in learning phase. So we need it's a steeper curve. So previously when we are starting our practice, we are just identifying the tendon, just injecting off. We don't know what's happened inside. So the technique, the thing was we are just injecting. Nowadays we are trying to see how the tendon was. We are trying to do more of diagnostic than a therapeutic ultrasound. So obviously it is a performer, and if I am having a very good machine, for example, if I am having a good machine which has got good Doppler, obviously they will have a better advantage. Otherwise, if you are using a simple machine, yes, there may be disadvantage of using ultrasound. And most important thing, right? So whenever you are not seeing the patient clinically and you are just putting the probe on the patient, and you may have a chance to see something which is abnormal. For example, if the patient is a diabetic and you are putting the probe on your supraspinous tendon, you may see some pathology over there. So there may be a mild or moderate tendinopathy. Doesn't mean the patient is symptomatic. Okay, so most of us, we say tendinopathy is basically a clinical diagnosis, and it is supported by ultrasound. Don't look for the ultrasound images first, then you try to correlate it. It's a wrong way of doing. Always tendinopathy is a clinical diagnosis, right? So coming to the general protocol, I'm not going to be very specific. We are just going for general protocol. So it's applicable almost for all. So two images are needed. One, we need an image which is long axis, another which is short axis, right? So long axis means you can see this is a tendoachilles tendon which is in the long axis, and this is the short axis, right? So what are the structures which we can see is, we can see the whole length of the tendon from almost near the muscular tendinous area up to the incision. So long axis is usually used for assessing the pathology, whether it's a proximal or distal, right? So when I'm going for short axis, it will give you an idea whether it is superior or inferior, or whether it's a medial or lateral, right? So most of us, we say, whenever you're going for large tendons, for example, Achilles tendon, when you're going for your supraspinous tendon, when you're going for your biceps tendons, so hamstring tendons, right? So the best way is go for short axis first, because you can see the structures in a better way and you can see the pathology nicely. Then you do in the long axis view. But when you are doing, for example, for flexors of your fingers, always do transverse axis first, means long axis first, then you go for short axis, because the long axis can be a better, we can get the images in a better way, and also the pathology can be easily identified for smaller tendons. One more thing, whenever you are doing ultrasound with tendons, be aware of anisotrophy. So this is the thing which you always has to play. So the only thing, it has got advantage and disadvantage. Whenever you are seeing a two structures, which is a tendon and a nerve, so you are a little bit confused. You can just tilt the probe, right? The nerve don't have any anisotrophy, but tendons will have anisotrophy. So this is the most important thing which we can use it for an advantage. But again, so anisotrophy is again important whenever you are suspecting a tendinopathy and it is hypoachic. Always make sure you had tilted the probe in adequate angles, so that you are proving that in all angles it is dark, right? And one more thing, whenever you are seeing some tendons, don't just look at the tendons. Look for the surrounding structures. Look for the fat, right? Bursas. So this may be the indirect signs which may give you an idea. So you can, for example, in long axis, you look for the bony insertion area, cortex. Don't just look only on the tendon, just look for the up, down, cranial, and caudal direction. So look for almost all structures, because sometimes you may have an indirect sign of tendinitis, right? So the most important thumb rule. So whenever you are doing an ultrasound, you should not complete the ultrasound without doing power Doppler or color Doppler. You have to put a color Doppler. You have to check for the neovascular, irrespective. It's a rule of thumb. Before you do any procedures with ultrasound, always put Dopplers. Or you want to make some diagnosis, once you had done, you had seen the echogenicity, everything, put in Doppler, confirm it, and come off, right? So whenever you are doing Doppler, the most important thing which we have to be very careful is, we are not supposed to give pressure, because these are neovascular changes. These are superficial tendons and the vascularity will be very less. So whenever you are giving some pressure, it may collapse, right? So always you can say, we can put good amount of gel, and you can use the floating technique. No need to keep even in touch with skin. Just you float it off. Put gel in between and see. That is the one we are supposed to do. Another thing is, you always have to keep it at 90 degree, 2 to 3 minutes, so that you can see the Doppler nicely. Then what are the features? Okay, these are the general protocol. I have to take a long axis, short axis, look for the anisotrophy, look for the surrounding tissues, then look for your indirect signs, then you put the Doppler, right? So what is the thing you are supposed to see inside the tendon, right? First thing you have to look for the tendon thickness, right? So now you can see the tendon is smooth. There is no bulge. It's coming out nicely, right? You can see that it's almost of same diameter, right? So in attachment, now you can see some anisotrophic here, right? So this is acceptable. If you tilt the probe, then you can see it off. So now I am looking for the tendon thickness, and I am looking for how the tissue was, how the fat was. I am looking for any bursa here. We had got retropetal bursa here, right? So there is no signs of bursa, and you can see the fat which is not edematous. Edematous means it will become more hypoechoic, right? So it's nicely seen, right? So this is the one first I will see. I see for the tendon, then I look for the echogenicity inside the tendon. So I had told you have to look for the typical fibrillar pattern. This is called the typical fibrillar. You can see the straight white hyperechoic lines, right? This is the typical pattern for tendons. So this is in short axis. You can't see the typical, but you can see multiple dots, right? In between, you can see something here. So this may be because of either because of this anisotrophy, or because of, it may be because of your previous vessels, or it can be because of some we can say tendinopathy. Okay, right? Then we look for neovascular. I told whenever you are putting a probe, always complete the final portion with vasculature and come out, right? What are the secondary signs? Okay, first I told how you look for tendon. Second, now we have to look for the secondary signs. What are the things? You can look for effusion over here. So any effusion here, any bursitis here. Then you can look for any cortical erosions here, or any chip off. So irregularity in the bone, or you can see some part of bone which is chipped off. Then you can see something over here, some peritoneal, some thickness, right? So it has got paratenon. This is Achilles tendon. Achilles tendon has got paratenon. You can look for any peritoneal thickness here, right? So these are the indirect signs of tendinopathy. So just because I'm saying secondary signs, why? Because it doesn't make sure that you had got only tendinitis, and again, it is not at all used for grading also, right? So we will be just going for, again, further how we are going to do ultrasound in different tendons. Now we are going to differentiate, we are going to keep tendons in two types. One is called rotator cuff and biceps tendon. That we are going to keep it as a separate one. Second thing, we are going to keep non-rotator cuff tendinopathies. So these are the two important classifications we used to keep, because the grading is different for both. So here in rotator cuff and biceps tendinopathy, the grading is based only on the tendons, not on any nothing on that, not based on your paratenon, not based on your bursas, not even based on your bones, right? And again, we never put Doppler and grade. In rotator cuff tendinopathy, previously we have a teaching that whenever suspecting a tendinopathy, you see the tendons, how it looks like, how the thickness, how the echogenicity, is there any discontinuity in the fibrillar pattern, you have to look for, then they ask us to put for power Doppler. For grading tendinopathy, especially rotator cuff and biceps, the role of Doppler is not yet established. Here we can do it off, but it is not used for grading. Coming to the non-rotator cuff, here the grading is based not only on the tendon, also on the peritendinous tissues. And here the Doppler plays a major role in grading this tendinopathy, right? So we can again divide this non-rotator cuff tendinopathy into three types. One is tendon with paratenon. The typical example is your Achilles tendon and patellar tendon. Second thing is tendon with synovial sheaths. So all your flexors, extensors of the wrist and ankles are basically with synovial sheath. And finally, just like your rotator cuff, we had got some tendons which don't have paratenon and synovial sheath. So the example is common flexor tendon origin, common extensor tendon, and your hamstring tendon. These are the most common. That's why I had given this as an example, right? So how we are going to grade rotator cuff tendinopathy, right? So I had told you how to look for tendinopathy. Just put your probe in long axis, short axis. Just look for the thickness. Just look for the echogenicity inside the tendon. Just look for the continuity in the fibrillar structures. Then put power Doppler. So if you are able to see vascular genesis, yes, these are the things which we are going to identify that structure is having tendinopathy. Then how we are grade that tendinopathy? So we usually rotator cuff is graded into 4: grade 0, grade 1, grade 2, and grade 3, right? So this is basically for tendinopathy. It does not include your partial tear and complete tear. Those will be an extension of this clinical spectrum, right? This is grade 0. Yes, most of you know this is your humeral head, then your neck, then this is your superior facet of your greater tuberosity, right? Sorry, tubercle, right? So now you can see the typical parrot beak. So this is your deltoid muscle. you will have something here, but it's not nicely seen because this is a subacromial subdeltoid bursa. Then you can see the whole length of your supraspinatus tendon. This is the footprint, right? So this is the insertion part. So when I'm looking at here, I'm looking, the tendon is not thickened, right? It's almost like in parrot beak. You can see it's coming out and attaching here. Then there is no change in the echogenicity. This is in the long axis. Again, this is in the short axis. This is your biceps tendon. So this is your rotator cuff interval. Then I am saying this is your supraspinatus. This is anterior part, middle part, and lateral part. Almost all are echogenic. In between, I can see some hypoechoic. It is basically not because of the degeneration. It is because of the muscles. When you go more proximally, you can see muscles. That is the only thing we should always do, always be careful, right? So whenever you're doing a short axis, going more proximally towards the muscle, yes, in between the muscles, in tendons, you can see the muscles. So this is the thing which we say the typical rainbow appearance. So this, you can say this is called rainbow appearance of your humeral head. So here I can say the whole length is intact, echogenicity is fine, and in between I can see hypoechogenicity, but it is maybe because of muscles. But if I come more distally, I will be going more towards your superior facet and middle facet. There you will be seeing predominantly hyperechoic structures, right? Because of the fibrillar patterns. This is grade 0. Then grade 1. Grade 1, yes, it needs experience for you to understand, but still, if you compare this one and this one, you can see, okay, fine, deltoid is fine, your subacromial subdeltoid bursa is nice, but still you can see some effusion over here, and you can see it was thickened over here. So it should come like this, right? It should come like this, but it was thickened. So you can see loss of, there's a fibrillar pattern, you can see a lot of fibrillar patterns here, but still intermittently you can see hypoechoicity, and here you can see the it's predominantly involving your middle fibers. So I had told grade 1 means 25% of the tendon's cross-section area, right? So this is grade 1. So now here I am not putting power Doppler. I had told you for rotator cuff tendinopathy, there is no role of Dopplers for grading, right? Then we are going for grade 2. Now you can obviously you can see the tendon is so much thickened. Now only you can see some amount of fibrils here, some amount of fibrillar pattern here. Almost it's the whole length. You can see it's hypoechoic, right? And you can see it's thickened over here, and you can see some thickening over here, and you can see a minimal subacromial subdeltoid bursal effusion. This is the, again, transverse axis. You can see the biceps tendon here. Now intermittently you can see fibrils, right? So predominantly I can see hypoechoic. So grade 2 means it's involving 25 to 75% of your tendon. That is grade 2. So when I'm looking at here, bony erosions, yes, I can say small irregularity is there. So you can see small calcification there, right? So we can say it's moderate to severe, but to be on safer side, I'll keep it on moderate tendinopathy, right? That is grade 2. What is grade 4? Grade 3, it says that it's severe thickening with hypoechoicity more than 78% of the tendon, right? So if I'm looking at here, you can see the whole tendon is swollen and only few fibrils you can see, right? But otherwise, I can say the whole tendon has been involved, and you can see the whole tendon has been involved. So this is the feature of severe tendinopathy. So even this one and this grade 2 and grade 3, we are finding difficulty. This is grade 3, right? So the whole thing is gone out, and the whole thing is gone out. So it is grade 3, right? So the next clinical spectrum will be a partial tear, right? So moderate, severe, then it will go for tear, right? So partial tear, there are 3 types. One is your articular surface tear. Second one is bursal side. Third one is intrasubstance, right? So when I'm looking at here, so this is a normal tendon, right? You are able to see here. Here I can see the fibrils nicely over here, some good amount of fibrils. You can see some effusion over here, but still I can see a defect here, right?
Afu रहने बेटे नको निकला.
So going for short axis view, so again you can see the hypoechoic structure here. So you can see it's a linear, right? And you can see the edges sharply. So again, this is the one which differentiate your tear from tendinopathy. You may be asking, sir, how to differentiate the tendinopathy with tear? Okay, we will be seeing it in the next few slides. So this is another one. This is for the bursal. You can see the bursa has been impinging down, right? So you are supposed to have the tendon bursa like this, but you can see the bursa getting inward, right? So bursa getting inside the tendon, and it was in communication with your bursal side. When you're taking a transverse, yes, it's not in the continuity of your articular surface is good, but still you can see here, here. So obviously it is bursal type of partial tear, and this is called intrasubstance, where it won't be communicating with either with the bursa or with the articular surface. This is called intrasubstance. And finally, this is called we can say full thickness tear, right? So in spite of just having only this part, if it is expanding up to here, this is called full thickness tear. But again, it's partial only because it is not the whole tendon. It may be part of this tendon. For example, this is biceps anterior middle fiber. This we can say posterior. The part of your middle fibers may be ruptured. Part of your anterior fibers may be ruptured, or it can be combined of anterior and middle fibers. But most of the time, the tear will be predominantly on the anterior fibers, predominantly near your biceps tendon, right? So you can expect always a tear to be here, right? This is about the full thickness tear. And finally, complete tear. The total supraspinatus has been totally avulsed off. How to say? So if you look at this long axis view, you can see that tendon cavity is totally empty. So whenever it is an acute tear, sometimes it will be filled with blood. So whenever you are having acute tear, so on the day one, if you are seeing put in ultrasound, you may not see this hypoechoic. Sometimes it may be isoechoic because of the blood, or sometimes it will be hyperechoic. After days, it will become more hypoechoic, and finally it will become anechoic if it is only serous. So this is your long axis, this is your short axis. So here we can say we are not able to see any part of tendons here, and also from anterior to posterior it's totally empty. So this is supraspinatus complete tear, right? Again, coming for the rotator cuff tendinopathy is graded in 4, grade 0, 1, 2, 3, right? 1 means tendinopathy involving 25%, grade 2 is 25 to 75%, and grade 3 is 75%. Then next spectrum is your partial tear. Partial tear is of 3 types. One is bursal, intrasubstance, and articular. And finally, complete tear, right? So these are the clinical stages for supraspinatus tendinopathy, right? Or whatever. This is an example of supraspinatus. So what are the other 4 muscles which will be part of, what are the 4 muscles in rotator cuff? We have got subscapularis, supraspinatus, infraspinatus, and teres minor. Supraspinatus is very commonly involved, but still your subscapularis, infraspinatus, teres minor can be involved. Teres minor is very rare, but still it can be involved. So what is the practical step? Whenever you are doing a grading, okay, so I am talking about increased in tendon thickness, right? So from grade 1, grade 2, grade, I'm saying there was minimal increase, moderate increase, severe increase. Is there any numerical value? We don't have any numerical value for it. For example, I am not saying if your tendon thickness, for example, if a supraspinatus tendon is more than, we can say 2 centimeter, then obviously it can be to know. There is no absolute value in tendon thickness because it differs from patient to patient, from side to side. And again, so we never measure tendon diameter for diagnosis. But whenever you're going to intervene, for example, you are going to study. For example, you want to compare your corticosteroid with PRP injection or just tenotomy, yes, you can go for tendon diameter measurement. So usually what we do, from insertion, we do 20 millimeter cranial, measure the thickness. That is for research purpose. Or you want to assess the treatment, you want to document the treatment response, yes, you can measure, but it is not at all used for grading, and it has nothing to do with line of management, right? So again, I had told there are secondary signs which always gives you an add-on value. So bursitis, like subarachnoid subdural bursitis, bony erosions, they may give you an add-on sign, but they are not used for grading. So the grading is basically because of your tendon thickness, your fibrillar patterns, and your hypoechogenicity, right? Again, so I had told, so bursitis usually, for example, if a patient is having, for example, if the patient is having shoulder pain and you are putting the probe and you are saying subarachnoid effusion, don't expect a bursitis to be a primary pathology, right? So bursitis as per se as a single disease is very rare, right? Most of the bursitis usually coexist with some tendinopathy, right? And again, so there may be a chance whenever there is a pre-existing tendinopathy, we can put it in the reverse. Whenever the patient has got tummy, we are not talking about the young athletes, right? We are talking about patients who are above 40 years. So those patients whom you are seeing that the patient has got some tear, means the patient already has some existing tendinopathy. It's very rare to have ruptures without tendinopathy in older patients, right? And one more thing, there was early thought, okay, whenever you want to see whether it's a normal or abnormal, we always ask them to put the probe on the opposite side and compare, right? So whether there is a tendon thickness, so what we say, okay, put it on the opposite because the patient is asymptomatic, we can put it on the opposite side. No. So nowadays it is not at all recommended, but still it can be used, but never infer just from the contralateral image, right? Because most of the patients may have contralateral subclinical findings, right? So that may misguide you. So don't consider the opposite side as normal and make this one as pathological. Or you can say that tendon is that much thick, this side also it's same thick, doesn't mean does not have tendinopathy, right? So obviously the typical parabeak, the synovial, that subaqueous subductal invasion, or the concavity is slightly bulged out with hypoechogenicity, most probably that is tendinopathy, right? Again, the most important question, whether it's an acute or chronic tendinopathy. How do you differentiate with ultrasound? Again, I had told you, so ultrasound has got no value in saying whether it's an acute or chronic. One, I told you tendinopathy is basically a clinical finding. Okay, if a patient with 60 years comes to you with sudden pain or with doing some forehead some activities, doesn't mean the patient has got chronic, right? So acute means the patient has symptom on that side only, that time, but doesn't mean they will don't have features on tendinopathy. Yes, they may have features on ultrasound. So it is basically acute plus chronic is basically based on the history, not based on the patient's pain onset, not based on your ultrasound. But still, there are some clues which may help you. One is, so acute tear, basically tear, will be more common in the proximal side, but in case of chronic tendinopathy, or we can say the tear will be more on the distal side. We can say whenever the patient has got some proximal tear, we can say, okay, the patient may not have some tendinopathy, but when it is more on the distal side, yes, it gives you a good value that the patient had got some pre-existing tendinopathy. Again, bony cortex, there may be a chance whenever there is a chronic tendinopathy, there may be a chance there may be a chronic inflammation which is going over there. So there may be a irregularity in your bony cortex. I told you there may be some signs which may give you secondary value. So especially with moderate to severe, yes, there may be some involvement of bony cortex. So moderate to severe, I told it's a clinical spectrum. It never jumps from immediately to severe tendinopathy. It starts with mild, moderate, then goes for severe, right? So there may be a chance that you have some cortex involvement. So we can give you an indirect idea. Okay, this patient has got pain, but there was some pre-existing tendinopathy which was going over for many years, right? How do you differentiate a tendinopathy with tear? I have told you there is something hypoechoic. Even in those spot which I am talking about in stage 1, stage 2, stage 3, then I am talking about partial tear. How to differentiate a tear from tendinopathy? It's a very important thing. Whenever you're putting a probe and you're seeing something hypoechoic, you should know whether it's a tear or not, right? So how tear will be? Tear will be always linear, right? It will be linear. Either it can become craniocaudal, we can say superior, inferior, or it can be mediolateral directions, right? Or it can be anterior, posterior. So they usually in the linear pattern, then you can see the edges nicely, right? So they have sharp, irregular edges, and it will more hypoechoic. When you compare this one, this is more hypoechoic, right? So obviously we can say tears are always, not always, predominantly linear with sharp edges with more hypoechoicity. And again, whenever you are giving a pressure with transducer, it will be fluctuating. So it will have fluctuations because you will have some fluids inside, right? So there will be some fluctuation, that is for tear. What about tendinopathy? Tendinopathy are predominantly round in shapes, right? So you can see this may be because of anisotrophy, right? So let me take this one. So this is round. So there is no specific borders, right? And relatively it is more echoic than compared to tears. So these are the few practical tips we should use it to differentiate whether it's the patient is having tendinopathy or tear. Or what we can do, we can go for dynamics examination, right? So whenever you are stretching it, it will stretch more, right? Whenever the tear will become more widened. But in case of tendinopathy, it won't be stretched that much, right? That may be another sign how to differentiate between a tendinopathy versus tear. So coming to the second type of tendon, that is non-rotator cuff tendinopathies. Now we will be having tendon with paratendon. What are those two tendons? We have got patellar tendon. Another is your Achilles tendon, right? So I told you this is your Achilles tendon, this is your long axis and short axis. So I had told rotator cuff tendinopathy is not only grade based only on the tendon thickness, right? It is also including your we can say vascular structures, right? So here Grade 0 is normal. Grade 1 is mild with a same thing. It is 25%. But only thing is they will have weak spotty color forms, means there will be small vessels, speckles of, when you put a power Doppler, you will get speckles of arteries, vessels inside the tendon. That is your grade 1. When you are able to see some rod like, few rod like, that is grade 2. When you are able to see lot of rods inside the tendon, it is grade 3. Obviously, when you are able to see very good amount of blood flow inside the tendons, obviously it says that it is grade 3, right? So it is include for all. So means non-rotator means with the paratenon, with synovial sheath, without paratenon stenosis. This is the grading which we routinely use it of, right? There is one thing which is specific for your Achilles tendon and your patellar tendon, that's is based on your paratenon also. So here you will be assessing your tendon, not only tendon, in Achilles tendon and your patellar tendon, you will be assessing your paratenon. It's almost same, right? So here they will say it's predominantly hypoechoic crescents. We can say that paratenon will be thickened with a small, for example, we'll take an image of this one. Okay, so this is your paratenon, right? So here only this part of you will be thickened. This is crescent shape. This is grade 1. If it is predominantly involving the whole surface up to here, so more than 50%, it is grade 2, or we can say moderate. Whenever it is involving almost the whole part of your tendon, that is called, we can say severe. There is nothing called grade 3 here. That is severe type of. Okay, fine. So again, whenever you conduct Achilles tendon and patellar tendon, you have to consider few things which is very important. One thing, you have to look for your tendon thickness, you have to look for the hypoechogenicity, and added to that, you have to look for your neovascular genesis, right? So that is for tendon. For Achilles tendon and patellar tendon, you have to look for paratenon, right? So again, we'll just see some examples with some examples, right? This is grade 1. This you can see this is your Achilles tendon. This is your calcaneum, right? So here you can see there was a thickening right here with a small collection over here, and there was some collection over here. I am putting a Doppler, right? I can see a small speckles, one here, another one here. So those mostly this will be mild type, right? So this is again, this the whole length. You can see the fibrillar pattern is lost here. Here the tendon was thickened so much, but still I can't see any bursitis here. I have told grading does not involve bursitis. It gives you an idea. So if I'm looking in cross section, you can see the tendons, you can see the hypoechogenicity here. There was a thickening of your paratenon. Obviously, it is grade 2. This is grade 3. As most of you know, that is the most extreme form of tendinopathy. Yes, most you can see the vasculature inside the tendon and also in the paratenon region. This is the paratenon region and some amount of Dopplers here. So this is grade 3, right? So this is your short axis. Yes, you can see the whole tendon paratenon region has been thickened. Sometimes you can't see this hyperechoic. So sometimes you may see a clear halo, right? Because of anisotrophy, you can't see it off, right? So it doesn't mean it's a fluid here. It may be because of your thickening of your paratenon, right? So how to differentiate? Okay, we'll go for another one. So this is again an example of partial tear. Yes. So you can see the tendon is thickened and you can see a tear here. This is your long axis and this is your short axis. I had told you how to look for tear with tendinopathy. Yes, it's more hypoechoic, it's more linear, and it's more defined edges, right? This is for partial tear, very common, complete tear, right? So most of us may be seeing this sort of in sports injuries or those patients who have been doing, we can say, running activities, right? So here, if you look at this is the long axis, obviously you can see something dimple over here, right? So this will be your proximal tendon and this one will be your retracted distal tendon, right? This is your calcaneum, and between you can see something mixed echogenicity. So the mixed echogenicity may be because of your blood or because of your seroma, or sometimes if it is healed, sometimes the fibrous tissue also will have an impact like this. So this is a long axis. You can see the proximal end, you can see the distal end. In between, you can see a mixed pattern, maybe because of the blood or some seroma, right? This is for complete tear. So whenever you are able to see some part of your tendon, so some cases you may see a small tendon here. So that tendon maybe doesn't mean it's a tendoachilles, it is plantaris tendon. So always you should, whenever you are doing scan of your tendoachilles, always make sure whether your plantaris tendon is intact or not. Sometimes your plantaris tendon may misinterpret you that is a complete tear. Sorry, it's a partial tear. So obviously you have to rule out the plantaris tendon also. Coming to those tendons with synovial sheath, obviously this is the last form of our tendon, right? So what are those tendons? So all your flexors and extensors of your hand and ankle, right, of your foot are belongs to this type of tendons. So you may be aware of all your flexor tendons, all your extensor tendons here and also on your foot. Okay. So there are five variants basically. So one is called acute exudative tenosynovitis, another is acute proliferative tenosynovitis, another is chronic active tenosynovitis, fourth one is chronic inactive tenosynovitis, and finally tenosine tenosynovitis, right? So we are not I'm not going to make it more deeper, just for your understanding. In tenosynovitis, patients presenting with tenosynovitis, whenever you're putting a probe, more than 99% you will see a normal tendon, because the pathology is not inside the tendon, it is because of the covering, right? So this is your tendon, this is your extensor tendon, just an image of your extension tendon, and you can see some collection which is not purely anechoic, right? It's like a speckled one, right? This is basically because of some exudative pathology. If you are seeing more hyperechoic dots, it can be because of your crystal tenosynovitis. Sometimes in gouts, you can see images like this, right? But in between, you will see more hyperechoic. The hyperechoicity will be like this. So, but we can't, in acute cases, we can't see the post-acute shedding, but you can see multiple speckles of calcium, the gouty crystals deposited. That will be the one form of, that is the most common cause we can say for causing acute exudative tenosynovitis. Then second is acute proliferative tenosynovitis. Here, the synovium will be more hypertrophied, right? So in acute exudative, there will be some collection. The synovial sheath will be normal. But if I'm putting a probe over here, I can see some sort of hypoechoic with hyperechoic tendons. With in between, we have some hypoechogenic structures, right? So you can see hypoechogenic structures here, hypoechogenic structures here. This is a flexor retinaculum, and you can see your median nerve here. Sorry, it will be your most probably the flexor retinaculum here. So you can see multiple tendons here. Here you can see the tendons are of normal pattern, right? I can see the typical normal pattern of your tendon. But if I'm putting a color Doppler, okay, I can see multiple vasculatures here, right? So again, so whenever you are putting a Doppler on any anechoic structures, if you are getting Doppler, means it's not fluid. So if how to differentiate between a fluid and a synovial hypertrophy. So put a color Doppler and you are able to get color signals. Obviously, it is not the fluid, it is basically your synovial hypertrophy, right? So this is acute proliferative tenosynovitis. And finally, chronic active tenosynovitis. This is more common whenever the patient is having tuberculosis, those things. This is about decurvance. So we had got extensor pollicis brevis and we had got abductor pollicis longus. Now in between, you can see multiple septations in your tendon. So this is because of your chronicity. If you put a color Doppler, I can see I can see the synovial hypertrophy, and also in between you can see in the tendons also. So this is chronic active tenosynovitis. Otherwise, I can put it in this one. In acute exudative tenosynovitis, the Doppler will be predominantly outside the sheath. When you put in acute proliferative, the signals will be predominantly inside the sheath. When you are putting the Doppler in active synovitis, it will be predominantly inside the sheath and also inside the tendons. And finally, we have got stenosine tenosynovitis. I have not put chronic inactive. Chronic inactive means you will get a structure like this, but if you put a Doppler, you can't get a Doppler. Means it's inactive. There is nothing happening there. Usually it will be asymptomatic, right? Then stenosine tenosynovitis, the typical example is your trigger fingers, right? So these are the flexor digitorum tendons, and if you put it in long axis, you can see the pulley. So this is another variant of your tenosynovitis. I had told tenosynovitis is not a separate entity nowadays. It is basically a spectrum inside tendinopathy. So as I had told, so we had got rotator cuff tendinopathy, non-rotator cuff tendinopathy. In non-rotator cuff, we had got three variants. One which has got parotinon, another one is which has got synovial sheath, another one is tendons which don't have parotinon and synovial sheath. So these are the various spectrums of non-rotator cuff tendinopathies. Then coming to the end, okay, hope so. It may be a huge, maybe you may not be able to understand, maybe the terms and the clinical findings which we have saying maybe slightly advanced for you, but still it's not a difficult one to understand, right? So if you go and read those things, you can understand. So then we go for the treatment part. The most important part in treatment in tendinopathy is risk factor modification. So if it is acute, yes, go for risk factor modification. Then we can get physical therapy using focal ultrasound therapy, phonophoresis. What is phonophoresis? where we're using the ultrasound waves to transmit drugs inside. So usually when you see some physiotherapists using diclofenac gel and they use the ultrasound, this is to increase the penetration of diclofenac inside. Iontophoresis, sometimes they can use TENS current to penetrate inside. Yes, most of you may be knowing ESW, external shockwave therapy, right? Shockwave therapy, that may be another thing. This is very useful for calcific tendinopathy. So has got very good results with calcific tendinopathy. Again, the backbone of all the tendinopathy is your stretching and strengthening exercise. If it is not responding, yes, for acute cases, you can use NSAIDs. There are few procedures which we can do just to have a short-term pain relief. Most of the patients, whatever the interventions we do, may have long-term results, but basically that will have more predominantly have role in short-term, right? What are those procedures? We had got corticosteroid injection, which most probably you may be seeing a lot of procedures. Then ultrasound guided barbotage, then ultrasound guided PRP injection, and finally ultrasound guided tenotomy and fenestrations, right? So we are not going to go more deep into it. So just one thing I want to talk you about is what is called tenotomy, right? So tenotomy is nothing. So whenever you are doing, maybe people will be seeing people doing PRP inside the tendons, for example, in the plantar fascia or it can be patellar or in supraspinatus. What they do, they have multiple entries. They make multiple entries, right? So they make multiple fenestrations and they inject PRP. So if you are doing only entry, just doing dry needling in the hypoechoic area and coming out, that is called tenotomy. But you are injecting something PRP, so that is called PRP injection. That is a step for PRP injection. Here we will be just doing dry needling, allow our normal blood to come out, have anti-inflammatory reaction and heal it, right? In PRP injection, we are injecting some growth factors so that the healing will be more better. But the studies I don't have any reference which one is better. Okay, fine. So because most of us are nowadays started doing only PRP, I don't think so there was a comparison between tenotomy and PRP injection, but I will say, okay, PRP is having more advantage because we are giving some growth factors. The only difference between PRP injection and ultrasound guided steroid injection is PRP injection is always intratendinous and steroid injection is always extratendinous. That is the only thing which we have to be careful. The most final thing in calcific tendinitis is, so whenever this is very commonly done in shoulder, which has got very good results. The results are more favorable in supraspinatus than tendoachelis, right? So what we do, we just put the needle along the log axis. We just put the needle here. Okay. With the 2 ml syringe, we do vigorous front and back movements. We try to get the calcium inside. So we will mostly, there are 4 phases in calcific tendinitis: pre-calcific phase and calcific phase and resorptive phase. So first 2 are usually painless. So sometimes you are putting a patient on a supraspinatus and you are seeing calcific tendinopathy. It may be in this pre-calcific and calcific phase and doesn't mean the patient will have pain. No need to do any procedures there. If the patient is symptomatic and patient is having severe tenderness over that insertion area, yes, then you can go for this barbotage. Once you repeatedly aspirate, yes, obviously you can see the calcium coming out and the echogenicity will be better. So most of the time, there may be a lot of, we can say, discussions goes on. So if just aspirating a part of your calcium will make the patient pain-free. But basically, what we are doing, we are just breaking the calcium and we are creating some channels so that our natural defense mechanism will go inside and they will activate your resorptive phase. In resorptive phase, our body macrophages itself will absorb this calcium. So it's again, we are just like in PRP where we are inducing some inflammation. The same way, when you are putting a needle in your calcific tendon, right? Obviously, you may be inducing the tendon to go more on resorptive phase, or you may be augmenting the resorptive phase, and the patient will be asymptomatic as early as possible. This is about ultrasound guided barbotage. So just we are coming for end of this topic. Hope so. I had been tried to cover. And these are the references which I had used for my presentation. And final slide, we'll go for questions.
That was very elaborative and nice descriptive way, Gurumoorthi. So we had a great start for the new year. Today is a new year for all business class people mainly. So same way we started our new year with a bang. Thank you. Thank you very much. Any questions? What is ligamentization?
Okay, then let me go back. Can you read the question, sir?
Pardon?
Can you read the question?
Yeah, what is ligamentization?
Ligamentization.
Yeah,
It's look new term for me.
me too.
Okay. Uh, so, okay, it's ligamentization means something, it's a ligament. Ligament basically means which is a structure which connects your bones to bones, right?
Yeah, that is okay, but
Yeah.
then
So, but ligamentization in tendons, I really don't have an idea. It's really new for me. Those who are asked this question can also explain.
Raghav, you told us.
Hello, sir.
Yeah, what do you mean by
Sir,
ligamentization?
in some articles, sir, I have seen this term, so I couldn't understand the tendon characteristic changes, just like ligament. So they mentioned this term. So
In
I
what?
could,
Where they have mentioned it?
sir, in ACL repair cases, when they put grafts of tendon, then the characteristic of tendon changes.
Okay, so you're talking about graph thing. Okay, so
And
now that's a totally different thing, and that is not in our
Okay.
curriculum. One thing.
Okay,
And-
that's now we can understand, right? So we're
yeah.
taking the patellar tendon, part of your patellar tendon. So for you to understand, you should know what is called tendon, what is called ligament, right?
yes,
So tendon means which connects a muscle to your bone. That is called ligament, tendon, right? What is ligament? Which connects some bony structure to your bony structure. So for example, you are doing ACL reconstruction, right? So you are taking your patellar tendon. Basically, it's a tendon, right? So you are taking a tendon and you are connecting, you are inserting that in between two bones, not in between the muscles. That may be the term which may be explain your ligamentization.
Yeah, what he means to say is that when they do ACL repair, they take tendon as a graft, and ligament is little bit tougher than the tendon. So they wait till the tendon is means the graft is taken. Means there occurs some certain changes of fibrosis, so that it is more stronger. This is what I mean. I'm not sure about it, but this is what I understood from that. So that the graft is more stronger to bear the weight of the knee. So that is what we understand by the term ligamentization. Does that answer your query, Raghav?
yes, sir.
Yeah, thank you. So basically, in ACL repair, the most common graft is the tendons they take. So both are a vascular structure, but then we wait for the tendon to become more stronger so that it can function as a ligament, so that there is no anterior dislocation of the uh, anterior transition of the knee. So to control the anterior transition of so that is what they meant, and it takes around 6 weeks or so for it to become more stronger by means of fibrosis. So that's what they wait. Spoiler.
Okay, sir. Thank you, sir.
Okay, the other question is when to use steroids and PRP for tendinopathy.
So it's a very difficult question to answer because the search for the answer is still going on. So that we can say. But one thing, okay, for example, you are using an anti-inflammatory and you one thing you are going to use an inflammatory thing, right? So for Achilles, okay, we can say whenever the patient has got some paratenal involvement, I had told you the grading of Achilles tendon or the grading of your patellar tendon is based on not only on the tendon, also of the paratenon. So whenever there is an inflammation or involvement of your paratenon, so obviously steroids plays a major role. Okay. If there is no involvement of your paratenon, yes, PRP can help. But still, this is again, we are just giving this idea, just not from our recommendation, just from the articles which I had referred. So they say steroids works very well with those with paratenon. Obviously, I can say steroids will be involved whenever there is a peritendon involvement. If there is no peritendon involvement, then you can go for PRP.
So, if along with tendinopathy there is bursitis, then should we go for steroid injection or PRP?
So obviously, it's again, I told the peritendinous, obviously the bursitis is also a peritendinous structure, right? So
Yeah.
usually it will respond nicely.
using steroid response nicely.
Yeah.
Okay. Thank you, sir.
So there is always something which we used to say, whenever the structure is wet, use steroid, right? Whenever it is dry, use PRP.
Okay. Thank you, sir.
There is another school of thought also for this. Now, depends on what phase the patient comes to you. So, in rotator cuff, we are saying silent degenerative tears. There, if you use steroid, it will not help. So, clinical judgment is very essential. You just can't go by the word not to give steroid. Whenever you give steroid, you have to be very careful that in tendons, you should not be intratendons injection. And there have been many cases where they have injected in the tender Achilles and that landed up with rupture. So that is quite frequent. So that is one thing we have to be very careful about when giving injections steroid into the tendons.
I had seen patients with the tendon rupture basically because of steroids, not because of sports activity so far in my life.
Yeah.
So most of my cases which I had seen in complete year are basically post-steroid injection. Actually, blind approach.
Yeah, right. That's where the role of sonography comes in. So we can see and inject peritendinous, not intratendinous. But why risk it when in your early phase of career? So in that case, then PRP is better. But then you have to be. It's not a question of just giving PRP or steroid. You have to understand the clinical scenario of the patient. What is he presenting with? What is his age? What has caused that injury? Because most of the what happens is tendon is basically avascular. So it's a graded multiple injuries over a period of time which are not healed that leads up to this problem. So basically, majority of the time, what we are dealing with tendinopathy, those are patients with chronic pain. And in chronic pain, it's a weakened structure, not a more of inflammation. So their role of PRP comes into, or anything what you want to use growth factor will come into question.
So
Acha.
as
There is
we
one
get,
more question for you, sir.
so I have one more question.
Hmm.
As we frequently encounter MRI of shoulder, with reports like tendinopathy of subscapularis, tear of infraspinatus, along with subacromial bursitis. So what should be done in such cases?
So first you should know why the MRI has been done for that patient.
Okay.
Yes. So first thing in the clinical scenario, I told tendinopathy is basically a clinical diagnosis, not should be relied on only on this MRI or ultrasound. So you have to correlate those findings with your clinical things, right? So for example, if the patient has got pain on internal rotation, obviously it can be a supraspinatus tendinitis, right? So you have to correlate those findings. If it is correlating with your clinical findings, yes, you can decide. So first thing you can either obviously the conservative management, it fails, then it's, yes, we have discussed whether you can go for steroid or PRP based on the tendons condition. So only thing is MRI is not a guide for your treatment. It is the clinical diagnosis which is going to guide you.
Okay, sir.
And one more thing, we always have an intention of putting steroids everywhere, right? So initially when we are doing practice, when we had been not experienced of those things, so whenever the patient comes with shoulder, usually with rotator cuff tendinopathy, so my style is to inject around all tendons. So we go on the rotator cuff interval, just go anterior to the rotator cuff, inject inside over the supraspinatus, go inside the rotator cuff, inject, come out, put it on the subacromial subdental bursa. So subacromial subdental bursa will be covering all your supraspinatus, even part of your infraspinatus. So those are the ways we did it during our initial practice. Still, I remember those days. But nowadays, it should be very focused.